Thanks, Philip. Now, I might try without the microphone, but if it's difficult, would you please put your hand up and I can always run. And thank you, Ashvan, for the opportunity. We're also going to try and do something very similar on the Seremban campus next week, so that the faculty there have an opportunity as well. But I guess what I wanted to do was, rather than a formal presentation with slides and everything, actually give some comments around medical students and mental illness. And I guess it's actually not only just medical students and mental illness, but it's basically in many ways anybody in an organisational structure with mental illness. So my experience goes back to running a very busy mental health service in Canberra, population of 400,000 people, and we were lucky enough to have in the end, close to 40 psychiatrists and 36 training registrars and a number of other physicians that would actually look after both an alcohol and drug program, but also the physical health of patients in justice health, so in our prisons. In effect, that meant that until we produced an organisational structure that I guess had some clinical directors responsible for some subsections of mental health, there were in the region of about 90 doctors that would report either directly or indirectly to me. But I also had the responsibility for ensuring the welfare of our nursing staff and also our allied health staff. So in many ways, quite a challenge. And I wanted to say at the outset, thanks to Prof Nazima in Seremban, I had the opportunity to be taken into confidence about the two students recently in IMU who've actually been excluded. And that's obviously not only a traumatic experience for the student involved, but also a very difficult and painful decision for a faculty and for a university. I'm very certain from what I heard, not reached without a lot of thought about what was happening, and also attempts made on numerous occasions to offer support and treatment and indeed rehabilitation to those students. The question was asked of me, would it be possible in any way that we could, screen medical students or screen people applying to be medical students, I guess, to lessen the risk of those situations. And I guess my advice to that is twofold. Firstly, I don't think it is absolutely possible to screen, because most often these illnesses will appear during the latter part of adolescence and early 20s. And so, if you're screening younger people, they're not going to come up with it. And I think a screening tool is actually very blunt and very difficult. Probably more importantly, not all students with difficulties, with mental illness, land up reaching the significance of the two that have recently been excluded. And I want to enlarge a little bit on that through the talk. And so I guess the thing I think that universities and employers, and as I said, indeed any large organisations need to be very careful about is not actually by default increasing the stigma around mental illness, because 1 in 2 of us throughout our lifetime have the risk of having a depressive illness. 1 in 5 of us will have a mental illness through our life. And so, of this group here, there will be several of us that will have some, experience, mostly of which is totally recoverable, and we move on. And indeed, I think that's, in many ways the case for your medical students. So I want to suggest that I'm going to divide illnesses, and I won't necessarily, I might characterise the illnesses a bit later on in the talk, but I want to actually characterise all illnesses to start off with into 3 groups. And the first one I'm going to sneak and call it 1A and 1B. 1A is the very common sort of feeling that we see with usual stressors, student pressure and so forth, where someone just for a short period of time just feels totally up to here and is not coping. And I'm aware from my visits last year that you have in the IMU some very effective counselling, a very effective counselling service with counsellors, and certainly that's very much in which I would see this type falling into, that if you are aware of it in your teaching or in your tutoring, that you would maybe approach the student, link them up with the counselling service, and the counselling service then can move on to a greater level of support, usually liaising with Prof Phillip if need be. But certainly they're the ones that I'd say are almost transient. So you would find it's not going to be a long-term worry either for the student or yourselves as faculty, or indeed for the reputation of IMU. The second part of this 1B, I want to describe as this, as a usual presentation of a serious mental illness. So it could be major depression, it could be one of the anxiety disorders, and that's going to happen maybe to that student regardless of whatever else is happening in his or her life. It may well be a genetic predisposition to depression and equally schizophrenia. And so they're going to present, I guess, with significant symptoms of mental illness that may have been developing for some time. We often use a phrase, something is not quite right. And trying to characterise that, it's, when you see an individual and you just think, this doesn't, I'm worried about this person. I just don't feel quite comfortable about their health. And so it's a signal, I guess, to maybe again refer to counselling or refer to mental health services formally for review. And of course, bearing in mind that your counsellors will actually have the ability often to sift these things through. I want to just give a couple of case examples here because I think they just embellish what I've just said. And the first was a young woman called Debbie, who actually was a fellow employee of my wife's in a government department. And she was, usually a very friendly, good worker. And then over the course of about a month, suddenly this young woman became withdrawn. She was not performing very well at work. She became very tearful. And she would be sitting at her desk and all of a sudden would feel completely overwhelmed, would run off to the bathroom, would have to be there for half an hour or more to just, pull herself together, and then would come back to the desk. And, if this event was happening maybe once a week, it might go unnoticed, but it got to the point that it was happening once or twice or more a day. And, my wife's sensing enough and has, I have to say with great respect, has learnt mental health by osmosis. And so, she knows a lot about mental health herself. Said to me, look, we need to do something about this young woman because I know she's been well and she can be well again. And so she actually came to my clinic and I looked at her situation, and there turned out to be a whole load of family stresses. She was aware of problems going on with her parents' marriage. She felt very much stuck in the middle of that. She'd had hopes of progressing her career a little bit and had been disappointed by not getting a promotion, even though she was told that it was indeed a good chance that she would receive a promotion over the next year. But all those feelings just clouded in on her, and she became, really, when you looked at it, significantly anxious. And so it was a presentation of acute anxiety, not able to function at work, and indeed progressively, struggling to function at home. Now, we often see in those situations where the presentation is acute that even though our talking therapies or psychotherapy will be the key to eventual success, that in actual fact at that particular point, what you do need to do is choose some effective medication to actually work. And not all that happens in psychiatry, if I say it this way, is in the textbooks. And I think that's the same for any other discipline in essence. But I mean, the standard treatment you would think for this young woman would be a selective serotonin reuptake inhibitor, antidepressant type, because they are extremely effective in anxiety. I found out that her GP had tried that and it had been an absolute disaster. She actually landed up getting hypervigilance, as we can do with some of those medications, and things just were she was really at her wit's end. I talked to her about various options, and we could have tried another SSRI. She was one of the ones where I had enough experience with acute anxiety that I used a very small dose of a medication called Quetiapine, trade name Seroquel, which is actually originally put through for schizophrenia. We've come to use it much more now in bipolar disorder. And the doses that you'd use in those situations would be anything up to 800 milligrams. Now, in actual fact, what I used for this young woman was 25. So an extremely small dose. Now, the thing to watch for here is people with anxiety that you give quetiapine to become quickly very sedated. And so the trick is to actually give it on a Friday and a Saturday night when someone's actually off work, and they can sleep through the day if they have a lot of hypersomnolence. And usually by 2 days or 3 days, that side effect of tiredness is worn off. She recovered spontaneously over probably a month. And then we spent a lot of time just looking at the issues that had actually promoted that acute anxiety. And I think probably one of the privileges, as in medicine itself, is to actually get someone, you know, from a very traumatic situation to being fully functional again. The other person I want to talk about is actually a member of a nursing faculty. So she was actually a teacher. Again, just presented with very significant major depression in the context of a marriage breakup. She was not only sad, I have to say, her predominant emotional feature was actually anger. And so her husband was actually being very manipulative, basically using the children as weapons. It was quite a torrid time for her. And she went from being a very functional junior tutor to basically leaving the university she was working for because she didn't see any way of being able to cope, and she was going to have to take on a full-time parenting role of those 2 children. So again, the addition of a serotonin reuptake inhibitor antidepressant this time was very successful. She took about 6 months, however, and that's not uncommon. And I think one of the take-home messages I want to leave with you is, you know, these medications sometimes do not bring about a result quickly. And there's a lot of, I often say to my registrars, what we need to do is market the cure. And you need to be able to say that, you know, I'm going to give you this medicine. In a month's time, you may start to feel that you don't have the acute symptoms, but it may be 3 months or 6 months before you really can say that you feel better. And again, she was someone that actually took quite a lot of effort in psychotherapy to actually bring about a successful result. Now, this particular person, and you'll forgive me, I love stories. And I had treated this patient 20 years ago or so when I was actually working in Adelaide. And I've since worked in Hobart and then in Canberra. My wife's home is in Adelaide. We were back for family things. We went out for a lunch. And lo and behold, this woman, she was a very sort of evocative person. I hear this, "Peter!" from the other side of the restaurant, and up comes this person, you know, "I'm so glad to see you." And you can imagine I'm thinking, oh, like memory, like where, you know. And I was very lucky. She introduced her daughter to me, and all of a sudden it all fell back into place. But again, you know, a wonderful privilege that many years on for the person to remember the help that they received. And you know, I think that's the impetus for us as psychiatrists, because, you know, we do often see so much pain and dysfunction, which doesn't always get better, but at least, you know, getting the privilege to see someone that well is good. Now, the next one's not quite so easy. So, ironically, was actually one of the best friends of the nursing tutor. Oh, I should have said the nursing tutor went back to full-time work and is now an associate professor at the university. So, you know, a really good outcome in terms of her career and her confidence. She's well published, and you know, just a wonderful opportunity for her to sort of advance in her career. And so this next person, as I say, was actually one of the nurse's best friends, and she was more of a challenge. She had the illness or the presentation of borderline personality disorder. Now, this is the syndrome that, in many ways, I think anyone dreads to a degree, because it is a real challenge to manage. And I think one of the things within the university is you will have a number of borderline personality disorder students, and they are characterised by a sense of entitlement, a sense of absolute chaos in their life, demanding, putting undue pressure on everybody else, and often with threats of self-harm. Now, they're threats of self-harm that are usually parasuicide, and so it is not very often that these people will actually end their life except by misadventure. And so again, it's the sort of situation where they plan very dramatic suicide attempts. So they may actually take out, you know, 30 tablets or more of paracetamol, take them all, wait for an hour, ring their mother or their father or ring their friend and say, I've just done this, what are you going to do about it? And it's that hostility. It's not even, can you please help me? It's often that negativity there. And, you know, often from a therapist's point of view, we ourselves get frustrated and angry, which you have to try and hide, you know, from the intervention that you can make. Now, clearly the result of that is the person comes by ambulance to hospital, they have the treatment for paracetamol overdose. But just imagine if at 2 hours they ring and that person they knew would be available on their phone isn't available. And then their next friend isn't available, and then all of a sudden this actually turns into a medical emergency. And that's the type of parasuicide that these patients often present with. And so if you, you know, and I'm not trying to be rude here, if you do have someone that is in this category, my empathy with you, because they are tough to manage, and you certainly need to have the help of a professional colleague. And sometimes it's a bit of tough love. You need to actually draw the boundaries for the person, and you need to be able to draw the boundaries for yourself, because otherwise what they do is they draw you in to their web of chaos, and very soon you're the rescuer, and being the rescuer actually isn't necessarily a helpful idea, other than, you know, the acute medical event when of course you would do something. And so, you know, very often we actually set criteria for these patients on admission. There's very good evidence now to suggest that these patients do not do well with a long psychiatric inpatient stay. In actual fact, what they do then is they transfer the chaos onto the poor nursing staff, and they're actually, you know, trying to self-harm in the hospital. And so the process of hospitalisation is short, sharp intervention and an early plan for discharge, and the setting of boundaries. Like I said, the therapists need to set boundaries. So many a time I've had to cope with a phone call that says, well, I'm due to see you at 4 o'clock tomorrow, but I need to see you at 3 o'clock today. And that's not okay, unless it's an absolute emergency. So trying to contain their chaos, and the ultimate, the phrase I'd use is, the goal is to keep someone safe enough, long enough, that they actually mature from this syndrome, and they do. Some continue to go on to be chaotic for years, but many over the course of 1 or 2 years will actually suddenly mature and actually just never have episodes again. The concern is if with borderline personality disorder, someone also becomes significantly depressed, which does happen, and then you do have to treat the depression with all the care and concern that you would normally do, and you know, make some exceptions to those boundaries that you've originally set for the personality disorder. I'm just going to get some water. Now, the other illness that poses a significant, both for diagnosis and for management, is that of bipolar disorder. And again, because that affects about 2% of the population, in some of your students that will occur. And so the absolute wide swings of mood, the grandiosity, the irritability, the, again, entitlement in a different way to that of borderlines, and a sense in which you can see that person's normal reputation spiralling out of control. You know, and I've often talked to patients about managing this post first episode, and I'll come back to that. So in first episode, you know, admission is essential to manage the mania, to put someone on an antipsychotic to reduce the symptoms, and then to look at whether in fact we actually need to use long-term bipolar maintenance with mood stabilisers. The discussion I have with patients at that stage is that there's usually about a 48 to 72 hour window in which the person actually understands the mood is going high. And if they act within that time and actually seek help, very often we can diminish or maybe even prevent a manic episode. Beyond 72 hours, life is way too much fun. Why would you want to, you know, stop me, etc.? So they lose their insight. And so often talking about that 2 or 3 days just to be aware and to seek help. And of course, individual, you know, like a lot of these things, individual responsibility does have to come. So the person has got to take that individual responsibility to seek help. I'm hoping that in the university setting, the presentation of schizophrenia is a little more rare. It's 1% of the whole community. It's 1% across all cultures. So it doesn't matter which culture, the incidence is the same. And that's really our most serious mental illness, with delusions, hallucinations, with thought disorder, change in patterns of thinking. But the usual presentation early, and what we call a prodrome for first episode psychosis, is that people actually withdraw. And so it can appear a little bit like a depression. And so if you see that withdrawal in a student who has otherwise been a very high functioning, capable person, or you know, for that matter, is simply, you know, a good average student, but suddenly they're not, I think that's a real warning sign. And I think there needs to be, you know, some careful assessment about what that diagnosis is, because if it is schizophrenia, the earlier the treatment, the better it is. But I say, hopefully it's more the depression and anxiety and some degree of borderline personality that you'll see presenting. So that was my, as I say, my type 1B, illnesses that are going to present anyway. Type 2, and I want to dare to be a little bit challenging to you. Type 2, I'm going to nicely phrase as caused by the institution, so caused by the IMU. Not intentionally. I don't think anyone intentionally goes to make difficulty, but the pressures that go on, setting deadlines for assignments, setting preparation for exams, all the sorts of things that are part inherently of a university course, but I think are significantly more so for students in medicine. And so that pressure builds up. And, you know, I guess I want to encourage, you know, because our medical students increasingly, I think, are under pressure to perform for the university, for their parents. You know, I think parents, if I'm correct in understanding, you know, often give up an awful lot for fees for students to be here. So that pressure to do well And if all that just falls to pieces, then you actually do, you can actually get the presentation of depression and anxiety coming through again. And I'm hoping you see the difference between, someone that will present with depression for other causes versus someone that will present with depression because of the pressure they're under as a student. I guess empathy is important, that each of you as teachers understand these things and can do something about it if possible. We can't always give extensions to deadlines for everybody, but I think there are exceptions, and we can certainly look around, different examination assessments and so forth if those people need that help. The last group 3, is what I'm going to call sensational, and I guess the 2 excluded students fall into that. And so, where things just go completely off the rails and the person is disruptive, they're accusative, they're aggressive in their personality. Maybe also now increasingly, the fact that social media is there all the time. And so some of their illness actually becomes a public focus on social media, and their delusions, their hallucinations, their paranoia all becomes part of that. This may be part of, number 1 type of illness that it's developing normally, or it could be exacerbated by the other pressures of being a student. But nonetheless, both of those situations need urgent and efficient action. So just pulling a few things together and then time for question. Firstly, what can the faculty do? Firstly, be aware of students who are maybe just falling behind in their performance, or maybe students that you see isolating themselves and their personalities are different than they were. Be particularly aware of the fact, and I think maybe for Malaysia there's still some growth on people individually seeking help for mental illness. So a lot of people will not put up their hand and ask for help. And so, you as teachers will maybe need to be the instigators of supporting that person to receive the treatment and the help they need, and hopefully earlier, the earlier the better. It's no fun for students to be going through these symptoms. It's a very terrible experience inside their head, and anything we can do to minimise that and get treatment is quite important. But I guess also be aware of the stigma yourself. It is uncomfortable for society still managing mental illness. And so, being aware of that so that you don't maybe sort of withdraw yourself from the help that you could offer. Please refer. So don't feel that you have to manage this on your own. There's good supports in the faculty. There are good supports in the counselling service. Get that referral going. Just occasionally we need to be a little controlling at that point, and that's difficult because the student already feels out of control. But sometimes putting that control back. In many instances of mental health treatment, 6-12 months down the track, I've had a patient that comes back to me and said, "Thank you for taking control when I couldn't." And that's a really important thing to bear in mind. Someone's not going to voluntarily all the time seek treatment. Be aware maybe of the power imbalance. That's tricky. I mean, inevitably as teachers, there is a power imbalance with the students. And so, if they approach you, I think it's probably fair to say they're actually fairly distressed. And they've actually made that big step to trust you individually. Some part of your ability to support and teach them has made them think, I can trust that person to get the help I need. But, be aware of that. Now, I want to give 2 personal examples. Because I had a little struggle at med school because, and I think actually Ashfan's gone, so I was going to tease her, I hated pathology. I couldn't stand it. And our pathology was started at the last semester of our 3rd year of a 6-year course. And we had a professor that believed absolutely that his specialty of pathology was the best. And he actually would focus on a number of us that were not doing quite so well and said, I will fail you. Buck up your ideas or I will fail you. Now, I'm hoping that that doesn't exist anymore, but I'm saying be aware of it because maybe just in the way we interact or whatever else, we give that message. Now, I failed it because he set up such a situation of fear in me that I actually failed his course. Now, I did some remediation and survived, but it wasn't a pleasant experience. Now, equally, in 5th year, we had a professor of obstetrics and gynecology who made, I think, half of our class do some sort of remediation. Now, that's crazy, because half the group of students isn't that bad. But, he had an absolute, again, belief in his own specialty. And I still have this date, the 1st of July, 1988, etched in my head, because that's the last time I had anything to do with obstetrics and gynecology. Now, what a pity, because, the influence of that person could have been so good that it was actually harmful. Now, as I say, I think they're fairly gross examples, but I just thought it would be worthwhile sharing those so that, we get that flavour of just how our presence can actually affect how students see us. So lastly, look after yourselves. Being in the university faculty, I think, is also a stressful job. And so, self-care, being aware of your own emotions is important. And being able, if you do have a challenging student, to be able to debrief, to be able to have a member of your, a colleague that you can say, oh, God, that was hard. And I mean, I think we all know that, particularly in our situation, if they recorded some of our tea room conversations, we would be sacked. Because the ability to debrief, you do need to be able to say, that was really tough, and gee, I'm really sick of the pressure I feel under to manage that borderline student, etc. So in the right situation, don't be afraid to debrief so that you can go out there and be strong and be purposeful and be helpful. So look, I think that, as I say, what I wanted to do was, raise a number of things both on illness and on management and on our own handling of this that actually, gives you the encouragement that, this is doable. Within the university, that we raise awareness of these issues so that they don't become the real difficult ones that then lead to a student having to leave. So look, open for questions. We've got roughly a quarter of an hour if you've got issues you want to raise with me, and they can be very wide ranging. They can be out of this topic if need be. Oh, no, that's fine. That's fine. I'll come over and listen to you.
You mentioned something about society not being able to be in a place where they're comfortable enough to talk about mental health issues and stuff like that. So what do you think is the first step that we as a university should take so that the students are more comfortable with their mental health issues?
Look, I think that's very fair. We had a question earlier this morning. Actually, I'll go back so that the camera's on me, I think. We had a question this morning in another forum around teachers and awareness of mental illness, and I think the principles apply to schools and also to universities, but also to workplaces. And increasingly, I guess I've seen in my clinical lifetime the ability of organisations to actually acknowledge that these illnesses do exist, to have education sessions for staff, I guess a little bit like today, to encourage people to do a little bit of extra research, to have some confidence in the faculty members in psychological medicine, that you can actually ask things. And so in many ways, I think, whilst it's a privilege as a guest speaker to come and talk to you today, equally Prof. Phillip could have done a very similar presentation and maybe could have had it, more relevant to the IMU because he knows the structure. And so, use the faculty. But on a wider level, and I'm encouraged by what I see happening in Malaysia. There is an increasing willingness to be more open about this. I don't think it was there as much 10 years ago. And so I don't want to be smug and say, Australia and indeed where I originally came from, New Zealand, is way in advance of these things, because there are many things that you do in mental health in Malaysia that actually are better than we do. The family structures are far more resilient here, whereas the nuclear families in Australia, take their loved one to the doctor and say, you sort it out and we'll pick the person up when they're well. And that's not good. And so, the efforts that are here to understand, but I think that's got to increase a lot in all cultures.
Maybe if I can add as well, getting governments and policy and everything else is, dream that it take years and decades to see happen. So I think we're going to work with our own communities. And so, for example, if it's IMU, then we work with IMU, organize NGOs and bodies and associations that focus on mental health, and make that relevant to what we are doing. Because the focus gets taken away to some sexy new thing, and or cure cancer, or cure that. And the real issues are mental health issues that are being swept under the carpet and not discussed and talked about. So I think the experience in Australia and all that is the NGOs start showing the path of the way forward. And that's people who are interested in helping the community. They don't get very much in return, but they actually build resilience in people within the community, and then others follow suit. And so I think if you notice, there are a lot of now NGOs getting the attention of people like Canberra and some of the other ministers. They're actually attending the functions which used to be done on their own. And slowly you can get the people in power to start thinking of change as well. So it has to start somewhere, and I think if we keep looking on top to make that change, we will always keep falling down. And I think we need to start with our own neighborhood and people that we work with.
Philip, I had meant to ask you, do you have a student assistance program in IMU?
No. Is there a student assistance program?
Is it called peer sharing? Peer support?
No.
Peer support. We do have the peer support.
No, it's like EAP. When you're an employee of a company, if you have a mental health issue, you go with confidence to get help and support from professionals.
Isn't that the
I guess it's a bit like the counsellors, yeah.
We don't call ourselves counselling, we call ourselves self-development unit.
Yeah, I saw that, yeah.
Behind the word counselling.
Right.
But under the counselling umbrella, we have the unit called peer support, where the peer go out to among their own peer and recognize who among them needs the support and to take them or walk them through to the
Great.
unit. Because under our act, we can't go out and get them.
No.
So we have to get somebody to get them to us, and then the treatment begins.
Right.
Now we have also put online talk to me, meaning that if the kids are not comfortable to talk to us in person, they can be talking to us online in an anonymous way, and we respond.
Good.
So the one that responds to them will be somebody close to them, not say close to them, the age-wise are closer, so they can understand and relate to their terminology, their language, and the things that they are going
Good.
through.
Yeah.
So we also tell them that these are all under P&C. But just now you were talking about we having our own community, but under that context, how do we ensure confidentiality?
Yeah. No, that's good.
Well, no, there's no need for confidentiality. First of all, it's developing a community that can actually feel comfortable in. So talking about things like depression, anxiety, worry, stress. So it's not a one-to-one. It's getting the understanding and knowledge.
And we have always had this challenge of doing group counseling, and we are those who join say, no, I don't have a problem. What should I be joining you? By joining that group, does it mean that I have a problem? So that becomes the issue that we have. So despite the fact that we tell them that these are all under confidentiality and we don't tell anybody, but when you meet the group, it becomes an issue. So we have to get them to sign informed consent that nothing goes out of the group, and some of them don't like it.
Yeah.
That is one of the challenges that we are facing when we want to do group counseling. So at the end of the day, it becomes one-to-one, but we have limited resources. There's the room, limited rooms, and our timetable is actually fully booked. We have gone out to use the clinic even.
I think if we look at it, you have mental health and you have mental illness. Mental illness has to be normally one-to-one. It's normally confidential. Mental health is everyone's problem. Everyone's got mental health issues. You have a bad day, you have a good day, that you need to focus on. That has to be university-wide. There's no need for confidentiality. I mean, it's like, let's all have a de-stress day today. Or tomorrow is let's how to manage anger and frustration. Or how to time manage. I mean, how much of that do we actually do? So we're just waiting for the big problem cases to come and then say, okay, confidentiality, one-to-one, this. But we've actually got the whole gamut of mental health that we haven't touched. It can start from having classes in the curriculum. Mental health is an important aspect of healthcare. And if our healthcare professionals have come out as mental health norms more than the normal population, why aren't we teaching them from university?
But having said that, I have to qualify that statement. IMU, we have a series of prevention programs, but we are having issues getting them to come.
Yeah.
Like,
Yeah.
They don't come.
It has to be part of the curriculum.
It's already part in the timetable. It's part in the timetable during orientation week. So I used to have by medicine 200 come. This is first week, but now 250 come. So where's 150? They won't come. They are not assessed. That's the thing.
Yeah.
You have an exam.
I guess I have my talk with the pharmacy. I'm supposed to have 90, but I think I only have 30.
Yeah.
So where did the 60 go? So ultimately we can have the talk, but we are having difficulty getting them to come. But now attendance is not compulsory for lectures, so lectures they don't come. So what about talks and hours? So here we are reaching out, throwing the rope, doing everything, putting the balloons, but they don't come.
Yeah. Now, I was just going to add one more thing to your first question, which is one of the organisations in Australia has, for a number of years now, had a day which we call Are You OK Day. Yeah. And mental health professionals and volunteers actually go out into the community, into the shopping centres, and they have literature around this and actually encourage people, who are not doing. And so, similar things can happen in other places. But it also made me think that one point I didn't add, and is probably quite crucial for anything, is in the work that you do, if a student is feeling depressed and starts to indicate some concern, don't be afraid to ask about suicide. It's often something that is uncomfortable. And there's a myth out there that says if you ask about suicide, you'll actually put the thought in the patient's head. Now, in actual fact, the person's had the thought in their head for a long time. And by talking about it, there's all of a sudden a sense of relief that really says, well, someone actually finally understands what I've been going through. And that can often be the link to treatment. So, now, sorry, you had a second question?
Not really a second question. I wanted to add on to what
Sure. Yep.
students not turning up for mental health resources that the university is already putting in place. Like, one of the biggest things is like, when you give the briefing to the students, at that point in time, not many people realize that they might have issues.
That's right.
Or, they don't really see it happening to them, so they don't really pay much attention. And usually when, somehow or other, at some point in time, when they do face mental health issues, like, they don't know where. So, like, that's also it's like a cause and effect of, like, students not.
I mean, just a thought, do students get a newsletter on email or anything like that from the faculty?
I'm not sure whether it's from the faculty, but there are resources on our e-learn portal.
Right.
But again, not many students are very
No.
interested in
I'm just thinking very often in a newsletter you can have, you know, a couple of extra things like, you know, remember you have the self-evaluation service, remember you have this, and so forth, that you could actually add in almost as a sort of advertorial.
We had that, but this year during our meeting with the students, SRC, I think you're one of them, right? Yeah. And then the students was complaining that the staff, is sending too many emails to them. And they're not accessing, they're not looking at it.
Right.
So,
Yep.
So they are saying that we should only send important
Right.
emails, and that they will just get the whole thing and then they just press delete.
Yeah. Yeah.
Along with it
Comes the other messages. Yeah.
So I mean, that's where student-led activities is important.
Yeah.
So instead of, you know, top down, it's going to be across. And, so Ramban, we have the Mind Matters Club. So these are students who actually organize events for students. So we are empowering and encouraging students to look after their mental health. And I think that's a more acceptable way than, you know, it's like their parents saying, eat at the right time, sleep at the right time. So now you are my lecturer and saying the same thing my parents say. But if other students actually tell them this is what they should do to look after themselves, it's more accessible. Yeah.
Absolutely.
Yeah, I think it's still very taboo subject. I just talk about my personal experience working in IMU clinic. So we have a team, and often the GP say, Nicole, I refer to you first, because they may not necessarily comfortable immediately with clinical psychology or psychiatry. So I can't be the front person to okay, I see this case, it needed a psychiatric, here's what I prefer. So I think we still needed a lot of awareness, normalizing how people see mental health. I think IMU Psychology Club doing quite a lot of activity to create awareness about suicidal, PTSD, you know, we talk about that. So I think that is also another platform where we create a lot of awareness through student activity. Yeah, this is what we're actually doing in IMU Club.
I personally don't know whether it's a benefit by camouflaging a word. I mean, I remember when I was in Bukit Padang Hospital, they changed the name to Hospital Masala. So you cannot call it Hospital Bukit Padang because people think mental illness. Masala is a word for happiness. Everyone still, you know, feels the same thing. You talk about Tandramutan and they call it Hospital Bhagya, Ulukinta. Everyone calls it Tandramutan. They know it's a mental institution.
Yeah.
So why camouflage something that's actually there? When you change anxiety or depression into feeling sad, feeling worried, that's not the exact word that is used for depression. So I don't know. It's,
Can we change that one from mental to some more?
Yeah.
You know, someone actually asked me when I start my clinic, Sultan, can you change your word that you find there? Not psychiatric clinic, but something else. Gynecologist. Read your mind through.
Yeah. You,
How do you get someone to acknowledge that something is actually wrong with them and they should actually seek professional help? Because personally, like I'm in semester 3 and this is the time we have our professional exams. I've had I think quite a number of my friends calling me like at night and they're over the phone like for 3-4 hours telling that you know that something is wrong with them. And you know that you are not the person supposed to be advising them because you yourself do not have the qualification to start
Yeah.
off. And you're afraid that what you say might not actually be what they are supposed to hear at the moment. But when you bring it up on the next day or like tell them perhaps you should meet or get someone and they're like, no, I'm perfectly fine. So how do you approach this?
yeah. Look, if I had a 100% answer to that, Philip and I would be driving gold Cadillacs because it's the challenge. So, you know, the initial, I think the initial effort has got to be about building trust. And I mean, we've got a fancy word for it. We build rapport with a patient. You know, now, you know, that is a tricky thing if, you know, mums and dads, friends, etc., out in the community, they recognise something isn't right. They want to do something, but they don't know what to do. But I think it is trying to approach it with a degree of openness, approach it with a degree to talk, and if through the talking something comes up that concerns you, trying in whatever way you can to encourage them to seek help. And you know, it doesn't always work. You know, there's you know, I think many a person has indicated regret that they wished they had you know, sought help earlier. But it's only when the person actually accepts that they need help. Now, we've got legislation in Australia that can force people to have treatment for a short period of time. I have to say, I think that's a very limited use, because until someone actually deep down says, this is my problem, you can make them go to hospital for a week, but they leave in a week and things are no different. If they go to hospital for a week and something about the trust, respect, and you know, acknowledgement of their issue happens, and they say, yes, I've thought about it, and yes, I do have depression, whatever, then you know, it's almost like magic can happen. You can get on with treatment, and then it's easy. But trying to get that first step, I agree, is really hard.
Yeah, so I think like one of patients that remarked was you know, her sister had been telling her, you should get treatment, you should see someone, and finally when she got to well, the end of the tether and everything, lost her job, lost her family, lost everything, she made the call to her sister, and she came in for treatment. And the first thing the sister said, this was the call we were waiting for.
Yeah.
So it's like that. They will hit a point where they say, okay, I need help. But who are they going to turn to? And if you decide, okay, look, I've done enough, I can't help you anymore, who calls someone else? And they've lost, you know. But one day they will understand that they, you know,
And-
be treated. You know, so the talk has to go around and people need to know that it's treatable, it will get better, and the link is there.
Yeah.
You go to treatment, I'll help you with it.
And in many ways, it comes back to your colleague's first question. So if there's more awareness about these things, people will find it easier to say, I need help. But at the moment, because there's less awareness, there's stigma, and it's not that easy to ask for help. People still withdraw. Philip reminded me again this morning, there's an organisation in Australia called Headspace, which was set up by the Early Intervention and Psychosis Services in Melbourne. So it's an independent service. It's free of government control, and so you know there's not the pressures of government services, but it's actually a step down from formal mental health care. And we actually find teenagers are very happy because it's like a drop-in centre. They're very happy to go in there and say, you know, my mum's annoying me. Or something like that, you know, and you know, it's that junction between, as you say, mental health and mental illness. And if they go in and then it's felt that there is a mental illness, then there's a link back to formal mental health services. Now, you know, I don't want to suggest that Headspace is perfect, but it's a really good step towards, you know, the support that you know, adolescents and young 20s will go to. We should probably draw to a close. So, you know, just again to acknowledge, thank you for your interest in coming today. I hope you've got a few tips there that will be useful. You know, I guess from my discussion with senior faculty members, I'm confident that they're going to be continuing to try to, you know, have services more aware of services and to look at what they need to do. So, thank you.